Hello, everyone. Good morning and good afternoon. My name is Walter Jayasinghe, the Director of Cultural Affairs at Sri Lanka Foundation and the Director of Operations at SLF Academy of Performing Arts. On behalf of the Sri Lanka Foundation, I'd like to welcome you all to Sri Lanka Foundation International Medical Webinar that we need to know about Omicron variant. The Sri Lanka Foundation International has hosted over 10 medical and business webinars, along with cultural webinars from the SLF Academy of Performing Arts to the community. We also have plenty of more other programs and events lined up for the near future. I would like to take this opportunity to invite you to the new school year open enrollment at SLF Academy of Performing Arts. The academy was formed by Dr. Walter Jayasinghe in year 2015 with the mission of serving the community by providing a platform to learn and retain Sri Lankan culture, language, heritage, and arts. The school achieved its accreditation status in 2019 from the Accreditation Commission for Schools, Western Association of Schools and Colleges, known as ACSWSC, pioneering the path to being the very first accredited Sri Lankan cultural educational institute. The free dance and drum classes are taught by highly qualified, extremely talented and experienced staff from universities across Sri Lanka and from our own staff right here in Los Angeles. Our academy will continue to conduct virtual sessions on Zoom and on Google Classrooms for the dance and drumming classes, as well as the on-site classes in the new school year starting in January 2022. Open enrollment is scheduled for Sunday, January 23rd from 10 a.m. to 12 p.m. at the school premises. Please join us. We also have scheduled the Paimpa ceremony, the graduation ceremony of the senior dance class students. It's scheduled for Saturday, May 7th. Then the virtual Sri Lanka Day Expo and Parade on July 15th, 16th, and 17th, 2022. The SLF Award ceremony on Sunday, November 13th, 2022. We invite you to join us on all these upcoming events. Now, before we begin, let me go over our disclaimers. This webinar is designed to provide information that is not intended for distribution or use by any person. The information presented at this webinar is collected, incorporated in good faith, and provided purely for the convenience of the purpose and for general purpose only. It should not be relied upon for any specific purposes, and no representation or warranty is given for accuracy or completeness. The webinar host has made every attempt to ensure that the information has been obtained from reliable sources, that the host is not responsible for any errors, decisions, or omissions of the information. The authors of hosting company will not be liable for any loss incurred due to the use of the information and material contained in this webinar. Thank you. And now, let's hand the webinar platform to our host, Keshini Vijayagunratna, the Director of Project Management and Public Relations at the Sri Lanka Foundation, and our co-host, Chamod Amarasinghe, the Media Director at the Sri Lanka Foundation. Over to you, Keshini and Chamod.
Thank you, Achala, for the greetings and the introduction. I'm going to keep my remarks very brief. I think Achala did a great job, with her opening remarks. Thank you, Achala, again. I'd like to start out by extending my sincere gratitude to our founder and chairman of the Sri Lanka Foundation, Dr. Walter Jayasinghe, who has dedicated over 50 years in the fields of medicine. Many people have written articles about Dr. Walter, and something that kind of caught my eye in one of the articles about him. And, he said, when Dr. Walter initially goal when he set forth as a young physician. He said, I quote, "I didn't want to create a need, I wanted to cater to the need." And I'm sure, especially the doctors, you know what he meant. This statement has a huge value in it. He formed the Sri Lanka Foundation in 2003. It is his vision that has brought all of us here today to educate and bring awareness to our global Sri Lankan communities on the new variant we are faced with. I also extend my sincere appreciation to the Sri Lanka Foundation President, Dr. Dishan Jayasinghe, and the Vice President, Ayesha Jayasinghe, for their valuable contribution. Also, my sincere thanks go to the Chief Executive Officer, Rodney PERAHERA, Chief Operating Officer, Shirani Stanislaus, Director of Cultural Affairs, and Director of Academy of Performing Arts, Achala Veerasinghe, and the Media Director, Chamod Amarasinghe, for their ongoing support. I couldn't do this without them. Chamod, do you have your video on? Chamod, he does so much behind the scene. Chamod, can people see you now?
Yes, Keshini, they can see me.
Thank you. Thank you for all what you do. Without our media director, none of us could host these webinars. Thank you so much. And also I want to thank Lal Tilakaratna, one of our most senior staff members in the Academy of Performing Arts, and also the rest of the staff members that are in the Performing Arts. Thank you to all of you for your support. I have to recognize another outstanding individual, Dr. Deepthi Jayasekara, the Medical Director of the Sri Lanka Foundation. It is his dedication and commitment that I have been able to host these webinars. And today I'm so honored to present an outstanding panel of doctors. They will be properly introduced by our Chief Operating Officer in a few minutes. It is so great to see Dr. Dushanta and Dr. Suranjit back again. Thank you so much for all your support. And Dr. Sanjay, finally, we were able to find a date and time suitable for you. It has been kind of hard to get in touch with you, but it was so nice getting to know you, and thank you again for all your support. And also, I had the pleasure of getting to know another amazing doctor from Sri Lanka, Dr. Neelika Malavige. I'm so grateful to all of the doctors for their valuable contribution to this webinar. Thank you. Dr. Walter Jayasinghe could not make it today because, as you know, he's in Florida, and I'm sure his time is very late, so he couldn't make it. He sends his apologies. I do have a message from His Excellency Ambassador Mahinda Samarasinha, the ambassador for Sri Lanka, United States. And Chamod, can we have his recording, please?
Greetings from the Sri Lankan Embassy in Washington. I want to congratulate the Sri Lanka Foundation Medical for an excellent initiative undertaken in organizing the International Medical Webinar to disseminate information on the Omicron variant. I'm also personally aware of the number of excellent initiatives that have already been organized and implemented by the Sri Lanka Foundation Medical, which has been extremely useful to informing the general public of important events, developments, as well as keeping the larger Sri Lankan community informed of very important events. I want to also take this opportunity of thanking the panel of experts, the doctors who have dedicated their time and knowledge to disseminating this very important information to the largest Sri Lankan community. I want to also take this opportunity of assuring the Sri Lanka Foundation Medical that the Sri Lankan Embassy in Washington stands by you. We are supportive of excellent initiatives such as this. I have no doubt that this particular initiative will be extremely successful. I look forward to receiving the information that will be disseminated by the doctors who will be serving as panelists. And I want to also offer the services of the Sri Lanka Embassy in Washington to supplement efforts of the Sri Lanka Foundation Medical to disseminate this information to the larger Sri Lankan community, because I know that this would be an extremely important as well as useful step that we would be able to take together in ensuring the public health of Sri Lankans who are living and working in the US. So once again, thank you very much for associating us once again with this excellent initiative, and I wish you all success. Thank you.
Our next speaker is the Honorable Consul General for Los Angeles, Dr. Lalit Chandradasa. Over to you, Dr. Lalit.
I'm very much thankful to the Foundation for organizing this webinar, because as you all know, we were thinking, in fact, even what I heard, what I saw in the media was that even Dr. Fauci thought 2022 will be the end of the pandemic, but now he has extended it to 2024. In Sri Lanka, we thought, the impact COVID-19 had in Sri Lanka. It really hit us very bad, but we were able to control it or get on top of it by immunizing everybody. As of today, there's 95% over 20s have got the first injection. Almost 80% has got the second injection. We have started giving the booster, and also we have lowered the level of immunization, age of immunization to 12 years. So I think that was the reason, or that is the impact of that was that we managed to overcome the very bad situation we were faced with. Now we have we are a little bit concerned, because we have almost we have got 3 positive cases of Omicron up to yesterday, and we don't know where we are heading. So I think this type of webinars will help us. They say it is very, very infectious, but not serious. Hopefully it won't be so. And what we are more concerned is whether it will be a resistance to the vaccination, in which case we in Sri Lanka will face a very, very difficult situation. So since most of these things are not known or are just emerging to come out, I think this webinar will help Sri Lanka, not only Sri Lanka, the entire Sri Lankan diaspora outside Sri Lanka. And I wish them success, and it will be a very lively discussion where most of the concerns of people can be, if not all, most of them can be resolved. Thank you.
Thank you, Dr. Lalit. Now, with great pleasure and honor, I invite our Chief Executive Officer of the Sri Lanka Foundation, Mr. Rodney PERAHERA. Over to you, Rodney.
Ayubowan. As I set the stage for the eagerly awaited webinar, it is important to recognize the vision of Dr. Walter Jayasinghe to initiate the Sri Lanka Foundation medical platform to bring to our global community timely topics of utmost relevance. A note of appreciation to Dr. Deepthi and Keshini for putting together this expert group of Sri Lankan-born medical professionals. Our profound thanks to the distinguished panel for devoting your valuable time to enlighten this gathering. So Professors Deepthi, Dushanta, Sanjay, Nilika, and Suranjit, we deeply appreciate your fight in the front lines. When I was at the clinic getting my booster shot recently, I engaged the nurse in some banter to ease the pain. We noted that the COVID-19 vaccination card has 4 lines for first dose, second dose, then 2 lines for other. So is it a total of 4 shots? So did the designers of the card at the beginning of the vaccine drive had some idea that 1 and 2 done may not be enough? And having served as an ambassador to Greece, I'm concerned that Omicron is the 15th letter in the Greek alphabet out of a total of 24 letters. Many of the vaccines we received as children to create immunities to infectious diseases last many years or even a lifetime. Flu shots are, of course, annual. Why COVID vaccines need second shots and boosters and possibly more? We know that the 1918 pandemic caused an enormous impact on humankind. According to the CDC, with no vaccine to protect against infection and no antibiotics to treat secondary infections, control efforts worldwide were limited to certain interventions, which were applied unevenly. The pandemic eventually came to an end, according to CDC, due to public health measures and herd immunity that was achieved by the colossal amount of infection. 1/3 of the world was infected with the flu, and eventually so many people either died from it or had immunity that the disease had nowhere to go. We know that current conditions are vastly different, of course. There's obviously much more global travel, and avenues for rapid mutations are immense. Do we see COVID-19 evolving and morphing into a seasonal illness with tweaked vaccines, boosters, and possibly natural immunity, helping us to combat the severity of the coronavirus in all its forms? I ask this since Pfizer said today that COVID could become an endemic disease by 2024, meaning it will not disappear, but become a vaccinated, protected ailment like the flu. So let's follow the discussion closely to gain a better understanding of what we are currently faced with. To our worldwide audience, I thank you for joining, and please continue to follow Sri Lanka Foundation on all media platforms for the wide range of programs featuring our 5 pillars scheduled for 2022. Allow me to convey season's greetings to all on this occasion. Thank you.
Thank you, Mr. Rodney Pereira. Now here's the moment everybody's been waiting for. Now I invite our Chief Operating Officer, Shirani Stanislas, to introduce our outstanding panel of doctors. Shirani, over to you.
Thank you, Keshini. It is an honor to have been asked to introduce a panel of eminent physicians today. I will not be able to read all of their qualifications and expertise because they are so wide and extensive. Our first speaker will be the moderator and the medical director of Sri Lanka Foundation, Dr. Deepthi Jayasinghe. Dr. Deepthi Jayasinghe, MD, FACP, MIDSA, infectious disease specialist from USA, is a board certified infectious disease specialist who has been practicing infectious diseases and internal medicine for well over 25 years. He serves as the chair of infectious disease at Eminent Health Hospital, San Dimas, and Kindred Baldwin Park Hospitals. A clinical professor at Western and Truro University Medical Schools. He has taken a leadership role in rolling out COVID-19 vaccines. He has published many review and research articles in scientific journals and recently wrote 8 newspaper articles for San Gabriel Examiner on COVID-19. As the medical director of Sri Lanka Foundation, he has been instrumental in organizing many Zoom webinars as a keynote speaker to our community on COVID-19 and other matters. Our next speaker is Dr. Dushantha Jayavira, MD, FACP, MRCOG from US. Professor Dushantha Jayavira has been working in infectious disease for two decades, and he is a professor in clinical Medicine at the University of Miami. Currently, he oversees the Infectious Disease Clinic at University of Miami Miller School of Medicine, Jackson Health System, where over 3,200 HIV-infected patients are managed. He has a designated HIV hepatitis clinic and also a minority clinic for Haitian patients. He has been a PI and co-PI in many NIH-sponsored studies in infectious disease, drug abuse, and the site PI of many industry-sponsored infectious disease studies, and published extensively on HIV and hepatitis C. He was the Executive Dean for Research and Senior Associate Dean for Research at the University of Miami Miller School of Medicine. He's one of the lead investigators in the Miami Clinical and Translational Science Institute. Our next speaker is Professor Neelika Malavige, MBBS Colombo, MRCP UK, AFHEA, Doctor of Philosophy Oxon, FRCP London. Professor Malavige is a professor in the Department of Microbiology, University of Sri Jayawardhanapura, Sri Lanka. She's a researcher at the Allergy, Immunology and Cell Biology Unit of the Department of Immunology, Molecular and Molecular Medicine of the University of Sri Jayawardhanapura, and was selected as a member of the WHO Technical Advisory Committee on COVID-19. She's also a key member of Oxford University research team conducting COVID-19 antibody tests. Our next speaker is Professor Suranjit Senaviratne, Doctor of Philosophy, Oxon, MBBS, MD, DPath, MRCPath, MRCP, FRCP, FRCPath, FCCP UK, a professor and consultant in clinical immunology and allergy, Institute of Immunity and Transplantation and Health Services Laboratories, London, UK. Also at Navaloka Hospital Research and Education Foundation, Sri Lanka. Dr. Senaviratne is currently at the Institute of Immunity and Transplantation, Royal Free Hospital and University College London, and Health Services Laboratories, London, UK. He completed his medical degree in internal medicine and trained in clinical immunology and allergy at the John Radcliffe Hospital in Oxford. A Doctor of Philosophy in Molecular Medicine at the Weatherall Institute of Molecular Medicine, University of Oxford, as a Commonwealth Scholar. He has authored 252 journal publications. Professor Senaviratne is an international expert in immunodeficiency, autoimmune, allergic mast cells disorders, and immunogenetics. He is the director of the Center for Mast Cells Disorders and the president of the UK Sri Lanka Immunology Foundation, an organization that contributes to immunology and allergy education in Sri Lanka. Next will be Professor Sanjay Senanayake, FRACP, MAPP, EPID, MBBS, BSc Medicine from Australia. Professor Sanjay Senanayake is a professor of infectious disease and director of hospital at Canberra Hospital, lecturer at the Australian National University Medical School, as well as conjoint lecturer at the School of Public Health and Community Medicine at the University of New South Wales. His expertise in COVID-19. His expertise is COVID-19, Zika, Ebola, plague, influenza, measles, chickenpox, dengue, malaria, tuberculosis, chikungunya, hepatitis, HIV, AIDS, meningitis, infections, viruses, bacteria, antibiotic resistance, Clostridium, difficile, BRE, MRSA, CRE, WHO, hand hygiene. He has many publications. As a leading epidemiologist, he expressed concern the Western Australian newspaper that there have been multiple deaths from COVID-19 due to people developing severe symptoms at home, but not coming forward for testing or medical assistance earlier on. Thank you very much. Over to you, Dr. Deepti.
Good evening. Thank you for the lovely introduction, Shirani. So, for the interest of time, I'll dive right into the subject matter. Welcome, all over the world, from viewers from all over the world. So, good evening, good morning, and good afternoon to all you guys. So, right now, what we are trying to do is to educate or share our knowledge about the newest variant of the COVID-19 pandemic called Omicron. Omicron is also known as B11529. So these burning questions are: how come this particular one has raised so much, curiosity and paranoia, so to speak, right, among all of us? So, as you all know, we have had so far five actually variants of concern: Alpha, Beta, Gamma, Delta, and Delta Plus. And this is the sixth one, which is Omicron. So WHO recognized this as a variant of concern because it's been raging across the world for the past few weeks. Just to give you a glimpse of as to what's happening in southern African countries, South Africa reported about 400 cases per day in November, jumped to about 6,000 when that's early part of December, when they identified Omicron variant. So now we have so many questions that we ourselves like the answers to come forward with, but at this point, there's very little that we can expressively educate our public. But for this particular seminar, this particular webinar, we've chosen the most brilliant, most elite group of panelists who are all infectious diseases and immunology specialists from pretty much four corners of the world. One from the US, one from UK, and another one from Australia, and last but not least from Sri Lanka. They're all infectious diseases or immunology specialists and professors of their own of the universities that they're teaching. So without further ado, I would like to invite Prof. Dushanth Jayavira to talk about the new medications available, antivirals especially. I'm very excited about the new antivirals that have been submitted. The data have been submitted to FDA. I'm quite confident that within next few weeks we'll get the very first Pfizer Paxlovid antiviral, which can be taken just like Tamiflu for influenza, 5-day course, and cost about $400. So to tell us more about Paxlovid, Molnupiravir, and other antiviral and anti-inflammatory or inflammatory treatment, Prof. Dushanth Jayavira. Over to you, Dushanth.
Thank you. Thank you so much, Deepti, for inviting me. I'll try to keep my time to exactly 20 minutes. I want to thank the organizers. I don't want to take any more time. And please don't be embarrassed. Just call me at 2 minutes before 20 minutes so that time checks. So I don't want to take any time off from other speakers, and because I'm dying to listen to Suranjit and all my other colleagues. So my talk today is about the antivirals and treatment, but I may digress a little bit about the Omicron because I think all of you are eager to know. So I know that Suranjit and others will speak a lot about it. So I'll try not to dwell too much on it. So today's my talk would be about the drug targets and the effects of COVID-19 on variants, the convalescent plasma. I mean, that would be a great place for us to discuss this because especially with the Omicron coming, the use of monoclonal antibodies, the direct acting antiviral agents like remdesivir, we already discussed. I'm not going to talk about it. I just put it there. Favipiravir, I'm not going to talk about it because it's been shown that it doesn't work. But people are interested in molnupiravir, which is the first antiviral which has been approved at least in United Kingdom, but it's pending approval in the United States. And nimletrovir, which is the most difficult name to pronounce. Paxlovid, as Deepti said, is easier to say, with ritonavir from Pfizer. And then the two drugs that are currently being studied are fluoxamine and ivermectin, which I'm leading a study with NIH multi-center study. I'm one of the PIs for Miami. So when we get to the antivirals, these are based on basic knowledge about the viral genome and what it encodes. So all the drugs that are working are based on the genes that encodes RNA-dependent RNA polymerase, or the spike protein, or the membrane, or the nucleocapsid, or the envelope. So the drug development has been based on what genes do we target and how do we interrupt the life cycle so that the structural proteins are disrupted. So this is the cartoon of the life cycle. I'm not going to dwell too much about it because I think everybody knows this. But the nimletrovir and molnupiravir will act at level of polymerase and the translation of because molnupiravir is a nucleoside analog, so it'll block it'll create mutation, not mutation, it creates errors in protein synthesis. So let me get to monoclonal antibodies. So this is one of the things that we are commonly using in states. I'm sure in Sri Lanka also they're using. So currently we have taken off bamlanivimab and etesevimab off because they don't work against variants. So CASI, the Regeneron COVID monoclonal antibody combination has shown that it has effect against mild to moderate COVID-19. So currently we are using this quite often. So if anybody gets tested, at least in Miami, at University of Miami and Jackson Memorial, and we put them immediately as outpatients so that we prevent people getting hospitalized. The GSK drug sotrovimab is also available. It's not widely used. It all depends on what deals that the insurance cuts with, but basically these are the anti-monoclonals that we are using. So the Delta variant currently the predominant, but as Deepti said, the Omicron is coming very fast. I listened to Nilika's talks before. I mean, I'm sure this is happening in Sri Lanka also. Currently, the monoclonal seems to have in vitro susceptibility to against the variants, at least for Delta. But I have some more information. I'll talk about it later about Omicron. So with the monoclonals, again, we start within 10 days. And, and one thing to remember is that if you take them, the vaccination has to be at least delayed by 90 days because it could be, as a precautionary measure, the antibody treatment may interfere with the vaccine-induced immune responses. So you have to kind of delay it by about 3 months. And of course, we all know the Omicron is coming. And I think unless you were sitting under a rock for the last couple of days, you would have seen this in CNN or New York Times or even Observer or Daily News in Sri Lanka. And you can see these spikes coming on. So what's really happening in Omicron is that there are multiple mutations. I'm not going to talk too much about it because I'm sure Suranjan will talk. In the receptor binding domain and other areas, which leads to enhanced transmissibility, and also it has an ability to evade innate immunity. So it increases by doing all that, it increases the infectivity. I'll get to that in a little while. So these are the mutations that are happening, almost 50 amino acid changes in the spike protein. I mean, when people who do sequencing, they are shocked by the number of mutations that are seeing it. So, and I'll get to a little later what really it does, because the general assumption is that if you do all these mutations, that may be that you have a greater affinity to receptor binding of ACE2 receptors, and that it will increase the infectivity. But I have some data to show that that's not how it happens. So we don't think that there's any biological plausibility that there should be reduced susceptibility to molnupiravir or remdesivir or the nemiravir, which is the Pfizer drug, by these mutations, because they are working downstream, not at the time of viral entry. So this is an important slide. This was I got from Research Square. We are comparing the variants and the monoclonal antibodies. You can see that when you come to Omicron on the right-hand side, the red, none of these monoclonal antibodies will work against the Omicron variant. So we are now getting into a very dangerous area with this, because the first line that we have been using now, in at least in the States, is going to will stop working. And this slide came from open data from NIH. This is actually, I'm sure Suranjit probably will know all this. This just shows that how bad the vaccines are working against Omicron. This is open data. This data was captured 3 days ago. And this is the line here. That's what it shows, is that anything to the right, there is lack of efficacy, and to the left is increased efficacy. So you can see that some of these vaccines, about 100-fold reduction in the efficacy, especially the adenovirus vector vaccines, even the BioNTech vaccines, has decreased effectiveness with I'm sure I don't want to spend too much time because that's Suranjit's talk. So another interesting thing is that the serum from, there was a study came out from Germany recently, out a couple of days ago, references given there, analyzing the binding of Omicron receptor binding domain to the ACE2 receptor. So as I said, that we were expecting it to be binding more, but what we are showing is that the Omicron is not actually binding to the receptor as much as the others. I'll show you. This is the slide that I was going to get to. So one would expect the Omicron, being highly infectious, to be binding to the receptor much there's so much more affinity, but actually less. So the question is, if that's the case, how is the Omicron spreading so fast? The answer is that there are other ways of viral replication being more infectious than just receptor binding. I'm not a virologist, so I'm going to leave it to Suranjit and my other colleagues. So then comes the convalescent plasma. There are multiple studies. We just got a paper out this week on JAMA on convalescent plasma, showing that it doesn't work unless you give it very early. So there are multiple papers saying that it doesn't work, but the recovery study said that it doesn't work. And then the study from Libster showed that there is some activity early. So the Concord study says it doesn't work. But the question is there a place for convalescent plasma? What we should consider is that the convalescent plasma may become important when Omicron comes, because if everything else starts failing, one of the beauties of convalescent plasma is that if you take the plasma from the same area with a high titer, and if you give it early in the disease, then it works. So I think there is a place for it. So if vaccines may not work, consider COVID convalescent plasma in Sri Lanka, because it's easy to do to get the plasma and use it, and it is much cheaper than what is currently available in other places. So now I'll switch gears and go to molnupiravir. Molnupiravir is a prodrug that is broken down in the body to form pharmacology active ribonucleotide triphosphate. It's like some of these HIV medications. So they have nucleoside analogs. So it causes errors in the transcription, and so it works like that. So the treatment is 4 tablets every 12 hours for 5 days. No dose adjustment needed, and it works. So this was thing, but just what they presented to the FDA. One of my colleagues gave me a slide to me. So you can see the placebo is in blue, and the placebo is in gray, the red is in blue, the drug is in blue, and you can see there's a clear difference against all-cause hospitalization or death through day 29. And you can see this early phase interim population, there's a greater difference, but the full population, the difference is. So this is a cautionary tale about looking at studies early. All these pharmaceutical companies want to put out their data saying that my drug works very well, but it's always, there's an ulterior motive. So as physicians and people who take care of patients, we have to look at the whole data set before we make a decision. So this again is showing the hospitalization and death. There were not a single death in the montelukast arm compared to placebo. But there's a small caution. That's the reason why US has not approved this. There are bone, cartilage, embryo-fetal toxicities. So there is potential for mutagenicity in fetuses. So we have to be careful whether this is really going to take off. So then the nirmatrelvir is actually a different agent. This is a protease inhibitor. Again, in viral diseases, we use it often. It's pan-coronavirus activity. I mean, obviously, the virus can mutate against these drugs. Viruses always beat us. So, I mean, that could happen. It's as a 3-pill, 2 nirmatrelvir and 1 ritonavir twice a day for 5 days. So, and this is really important. When in the randomized, there are 2 studies they are done. 2 studies. One had 0.8% who received nirmatrelvir hospitalized through 28 days compared to 7%. So the huge difference with the p-value of 0.0001. And no deaths were reported. No deaths were reported compared to 10 in the placebo arm. And this record shows that. And then safety, that was pretty decent. There was no serious adverse events, mild adverse events, nothing to write home. And then there was a second study which showed the same thing. So the FDA normally expects 2 randomized control studies before they give full approval. So my prediction is that nirmatrelvir will be approved FDA before the montelukast because of these 2 studies, minimal side effects, no tetragenicity, and it's 5 days course. And it's amazingly, it works well. So this is the second study I was talking about, EPIC-2, evaluation of protease inhibition on COVID-19. And again, I'm not going to repeat that. I'll skip that and go to the next one. So it's likely that they're going to be approved. I mean, ritonavir is commonly used in HIV drugs as a PK enhancer. The problem with ritonavir is that it has some GI side effects, but the tablet form of it is not that bad. Okay, so it's not a big deal. It's only for 5 days anyway. So then comes the fluoxamine. Now, fluoxamine is a drug which is used for antipsychotic and for psychiatric for psychiatric diseases. It has a mechanism of action toward the later stage of the viral life cycle. And so it's interesting that there was a paper published by Lenz and colleagues, double-blind randomized study with 152 patients in St. Louis area. And, 80 got fluoxamine and then 72 got placebo. And the primary outcome was hospitalization. What they showed was there was actually almost a 50% difference in the improvement when you compare to fluoxamine versus placebo. The difference was 8.7 with a p-value of 0.009. So that fluoxamine group had 1 serious adverse events compared to 6 by the placebo. So my prediction is that I'm currently running a study with the NIH comparing ivermectin, fluoxamine, and a steroid on outpatient population to see whether the patients do better with hospitalization. We have already enrolled almost 700 patients in the ivermectin arm. We have other, the fluoxetine arm is a little slower, but we are hoping to come up with a reasonable answer in the near future. So the most important thing here is that unless there is data, we shouldn't just use drugs with just by theoretical modeling or just by theoretical arguments. What we have found in COVID is that the most of the times when our predictions have always gone wrong. So we have to be very careful that we have full data set before we say this drug works or this just doesn't work. I mean, a good example is ivermectin is an antiparasitic drug. I mean, in vitro, there's very good activity. And there was multiple studies done. And Andrew Hill from, I think, Liverpool did a very interesting meta-analysis investigating 24 randomized clinical trials through PubMed and, wherever they're published. And it actually showed that ivermectin is associated with reduced inflammatory markers and viral presence by PCR. And it was, treatment and dose dependent, duration dependent. So there is data, but the data is not absolutely clear. So what we are hoping to do is to do this active 6 study and try to come up with a definitive answer whether ivermectin works or not. It's very interesting that the FDA recently published looking at all the applications that are coming to FDA. 95% of the studies that are submitted to FDA were not powered enough to give an answer. Just imagine the millions of dollars that we have wasted on studies which not powered enough to do. So that's why the Active 6, which we are running, is actually powered enough to give a definitive answer. And we will say whether it works or doesn't work. Currently, the WHO says, don't use it unless it's a clinical trial. So currently the CDC, I'm almost coming to my end because I want to keep to the time. And if you're not hospitalized, then we give monoclonal antibodies. Now, I don't know how long we will give that based on the Omicron, depending on how it works. We just wrote a letter to FDA saying that to approve convalescent plasma as a EU way for Omicron, because we think that if you can get a high titer for Omicron and early, that could be at least buy us some time before we start changing our vaccines and changing all the other things downstream. Now, as far as the pills from Pfizer or Merck, they too may be assist us in controlling outpatient. But inpatient, of course, there is the remdesivir and dexamethasone that we all have been using. And if the patients are on a ventilator, then of course you can use tocilizumab as an IL-6 inhibitor as a possibility. So this is the snapshot of what it is like, the current trends in treatment. So vaccines may not work against Omicron variant, but that's the best we have. So you might as well use it, because if you don't use it, it's going to be much worse. It has to predict what will happen with variants. Monoclonals is good for early COVID-19, but again, I'm not sure what will happen. As you saw my slide where, the more than tenfold resistance, EC50 has gone more than tenfold from what it was. Molnupiravir and elmetravir is good in COVID-19. So that may be it's a game changer. All the others are investigational, so I'm not going to recommend any of those. Remdesivir, dexamethasone is for hospitalized, non-ICU, and the ICU patient, obviously, you can give tocilizumab. So with that, I will stop and thank you so much for arranging this. And I want to thank Deepthi for inviting and the Sri Lanka Foundation for inviting me. I look forward to listening to my other colleagues.
Thank you so much, Dushanta, for that insightful presentation. But I have to tell you, when we talk about the COVID variants, we might sound as alarmist, right? But then again, we have to be very realistic, because this is a long drawn-out pandemic. So it is our role to educate everybody else, to be cautious, to be careful, because life is not quite back to normalcy. But those are the fact that we have two oral antiviral medications that you can take at home before the disease spirals out of control. That's a great development. Now, as you heard from Dushanta, these oral antivirals may work against the newer variants as well. But it is a variant with, it's a very bizarre constellation of mutations, and some of them actually affecting the receptor binding domain. So you have to be very careful. That's why we are very open about this. We are not alarmists, but we have to educate you. Dushant, yes.
The antivirals will not be affected by the Omicron variant because the mutations don't actually affect it that much. I mean, it may slightly, but it will not. So I'm very optimistic about the Pfizer drug more than the Merck drug.
Exactly. So as far as prevention is concerned, I have my 3M formula, which are masks. That's not going to change, right? Masking mandates or masking, that option is a great option to continue for the next few years. And mRNA vaccines with boosters, that's the second M. And then the third M would be monoclonal antibodies, as we discussed. Now, the latest one is a preventative monoclonal antibody. Those who are unable to take their vaccines or unable to take the boosters, AstraZeneca just approved Evusheld. The FDA just approved Evusheld, the latest monoclonal antibodies that last longer than others. So actually it lasts 6 months. The antibodies last 6 months with this one. So that's definitely a new tool that we should have talked about. I'm sure Dushant meant to talk about that as well. Let's get on with our second speaker, Prof. Neelika Malage. I think we have a video from her.
Good morning, everybody. Thank you for inviting me to give this talk in this session on Omicron organized by the Sri Lanka Foundation. So what I'll be talking today is about the Omicron variant and how Sri Lanka is preparing for a surge. As of the 15th of December, Omicron was present in 6 continents in the world. And in some countries, there is community transmission. So for instance, in the US and Canada, in many countries in Europe, South African region, India and Australia, we do have community transmission of Omicron. Now, Sri Lanka has been highlighted as Omicron detected typically in a traveler, but from our recent sequencing data, we now know that it is not just present in travelers, but we have detected in people from the community as well, who had links with travelers. Now, when it comes to the transmissibility of Omicron, I mean, when people saw how mutated Omicron was, everybody was very concerned. South Africa initially reported it on the 24th of November, and within a matter of 2 days, on the 26th of November itself, the WHO declared it as a variant of concern. So if you look at the other variants of concern like alpha, beta, gamma, the WHO took a few weeks, actually if not months, to declare them as variants of concern, whereas Omicron was declared a variant of concern within 2 days. Now, what is worrying about Omicron is the very high transmissibility or infection rates that you're seeing. So this is data from Gauteng province where it was first reported. And so South Africa had a poor vaccine uptake and because of this inequity in distribution of vaccines. And they had a huge first wave, which was with the original SARS-CoV-2 virus, then a beta wave and a huge delta wave. So people in South Africa had been had natural infection with 3 different waves, but Omicron just shot up and the cases increased, nothing like the previous, what was seen with the previous variants. And the forecast for UK, right now we know that UK is facing a huge surge of COVID cases. And when in certain areas like London, Omicron has already displaced Delta, And so England and Scotland are expecting the biggest surge ever when it comes to the number of cases. Hopefully, the hospitalizations won't follow the increase in cases, but we'll talk about severity very soon. And data, early data from UK is showing, at least when you look at the household transmission rates, the household transmission is significantly higher than for Delta. And because of this high transmission rate, the doubling time is estimated to be 2.5. This is the last Friday report on the 10th of December. But more recent reports are showing that the doubling time is even less than 2.5 days, which means there's a really exponential rise in the number of cases. This is a log scale, so you can see how the number of daily number of infections, how they're expected to increase. And earlier, although the infections were mainly detected in travelers in UK, now the non-travel associated infections are rising. So although UK has put out their data like this, so has Denmark, Netherlands, and all the countries which have been hit with Omicron and are having community transmission are seeing this surge in the cases of Omicron. And when it comes to variants or organisms, it's always survival of the fittest, and that rule applies to viruses. And when we know that when Delta emerged, it rapidly sort of wiped out all other variants, and Delta was the predominant variant globally for quite a long time. But when Omicron came, because it is more transmissible than Delta, it is wiping out Delta. In South Africa, I mean, there is no more Delta. When you look at the sequences uploaded during the last 2 weeks or so, and you can see that it's rapidly surging in many countries. In Sri Lanka, 1% of our sequencing is Omicron, but recently we have, I think it will change a little bit. And the important thing, apart from the transmissibility, why Omicron is transmitting as it is because the potential to cause reinfection. I mean, even with the earlier variants like Beta and Delta, they did cause reinfection in people who had natural infection. But because of the mutations in the Omicron, especially in the sites where the neutralizing antibodies bind, there's a higher immune escape associated with Omicron. So with Beta, there was a 12% relative risk of reinfection. With Delta, about a 9% relative risk of reinfection. But with Omicron, the relative risk of reinfection is 25%. So the ability of Omicron to reinfect people who have already been infected or have been fully vaccinated is one of important things that is driving its high transmissibility. Now, when it comes to how Omicron is likely to spread, it depends on the background immune level in a population. So this is a South African population. So when Delta hit South Africa, there were a large proportion of non-immune individuals. There was a few high-risk immunosuppressed individuals, and then there were people who were exposed, in other words, infected. So when Delta hit South Africa, there was a very high proportion of non-immune individuals. So Delta did what it did. However, when it comes to Omicron, because Delta already infected quite a lot of proportion, there is less individuals who are non-immune, but because Omicron can still infect people who have prior immunity, Omicron is able to infect a larger proportion of people. So the background immune level of a population through vaccination, the number of doses given, and the natural infection, all of them are likely to be important to understand the transmission dynamics of Omicron in a given population. Now, the transmission or the high infectivity of Omicron, apart from the immune evasion, the infectivity seems to be different depending on where Omicron can infect. So this is some beautiful data coming out of Professor Malik Piris's lab, where his lab and others show that Omicron is 70 times more infective for the bronchial epithelium rather than lung tissue. So it causes 70 times more infection in the bronchus, so upper airways, where the virus can be disseminated out rather than the lower airways. So the reduced infection in the lung can lead to less severe disease, but more infection in the bronchus can lead to more infection rates. So this is further explaining why we might be seeing higher transmission with Omicron. And there were some reports this morning by prominent virologists, immunologists saying that the transmission rate of Omicron is sort of similar to measles, which is one of the highest transmissible viruses we have seen. Now, coming to the Sri Lankan situations, our lab has been doing genomic sequencing of the SARS-CoV-2 virus from the onset of the pandemic. And we have detected so many different type of variants in Sri Lanka, most of them which are not of importance, but since of recently it has only been Delta. And the majority of sequencing has been in the Western province, and the Western province has been the epicenter of all the outbreaks of COVID. And this is just our recent sequencing data, which is the sequencing that happened, the samples, the origin of the samples that we sequenced during the last week or the second week of December. So we got samples from all over, but predominantly, of course, from the Western province. And we detected various subtypes of sublineages of Delta and Omicron as well in the Western province. I'll talk about that. So this is the timeline of how the variants emerged in Sri Lanka and disappeared. So we have data from late October 2020, because before that we didn't do much sequencing. There was not many cases to start with to do sequencing, but we got this COVID outbreak last October with the Brandix cluster, which was due to a Sri Lankan original SARS-CoV-2 variant, which was not a variant of concern. Then we had Alpha. Then, of course, Delta came, and we have two Delta sublineages, again, which is of Sri Lankan origin. But having said that, then, of course, Omicron came, and you can see that after later sequencing, 2%, because we only sequenced 94, by the way, so 2% were Omicron, and we have identified 4 individuals with Omicron in Sri Lanka right now. That doesn't mean that we have only 4 individuals with Omicron in Sri Lanka. It just means that of the small number of samples we sequenced, we have detected 4 individuals. So 1 person was an overseas returnee. 2 individuals were contacts of overseas returnees, but were detected from the community, but they did have some contact with overseas returnees. The other one individual is a person who was going to depart from Sri Lanka. So it's not a returnee, but an airport sample of a person departing from Sri Lanka. So it looks like Omicron is likely to be out there, and we'll have to accept that we do have a certain degree of community transmission just starting probably, and we will see it taking off like it is in other countries, because Sri Lanka can't be different to elsewhere. The important question, of course, is, rather than transmissibility, how severe it is. Now, when you look at the Alpha, Beta, and Delta wave, so this is the Delta wave in South Africa and Guangdong, where it was Omicron was initially reported. And you can see there was cases, admissions, and deaths have been sort of similar during the previous Delta outbreak. But there's decoupling when it comes to the Omicron outbreak, because although the cases are rising, the admissions and deaths have not followed equally. And so this is the total South African data again. In the Delta wave, you have high number of hospitalizations, people requiring intensive care in the Delta wave, which is so much lower in the Omicron wave. So, however, one important thing we need to remember is a virus that transmits more transmissible, kills more than a virus that is less transmissible but more lethal. So this is a virus that is twice as more lethal but doesn't cause a lot of transmission, whereas this is a virus that causes fast transmission and normal lethality, and fast but mild. So in the end, the infection that transmits as a higher transmission rate ends up killing more individuals than a virus that is more lethal but less transmissible. So we have to keep this in mind and be prepared for it. Now, how is Sri Lanka preparing for Omicron? is, of course, speeding up vaccination. So we have started trying to get the unvaccinated immunized, and also rolling out vaccines to school kids. And we are trying to get all the adults getting the booster doses. The booster dose uptake hasn't been great. And in Sri Lanka, unlike many European countries and US and elsewhere, people do have to wear masks everywhere. All the time, they're indoors or outdoors, unless it's their own house. People are, and in public transport, people are expected to wear masks irrespective of their vaccination status. And one important advantage that I see Sri Lanka having right now at this moment over many Western countries is the climate. Because we know that US, Europe, and so on are having a winter right now. So there's no way that they can keep their windows and doors open and have good ventilation. Whereas Sri Lanka, we know that all the windows and doors are open. We have ample opportunity for good ventilation, ample opportunity to meet outdoors, have gatherings or function outdoors, which would, because of the ventilation, lead to less transmission than you would expect in a country which is right now going through the winter. Now, Sri Lanka has not been doing bad as far as vaccination is concerned. It's actually doing better than US. We have like 64% of our population fully vaccinated, and about 74% having at least one dose. And we have given out 1.8 million booster doses, which is about 7.7% of the population as of 15th of December. So, and the idea is to vaccinate give a booster dose to every adult in Sri Lanka. But with the Pfizer, so the Pfizer vaccine is used as a booster dose. But because of the myths that are surrounding the Pfizer vaccine in Sri Lanka, the booster dose uptake has not been great. So how do we move forward? So we know how the virus spreads and we know what to do about it. So masks really help, ventilation really helps, and Sri Lanka is doing right as far as masking is concerned, and everybody is very compliant when it comes to masking, and we have the advantage of ventilation. Our schools also have the advantage of ventilation because of half walls and so on. We understand who gets severe disease and how to treat. I mean, we know much better than the onset of the epidemic. But these antibody treatments don't seem to be, most of the monoclonal antibodies don't seem to be working for Omicron, but I'm talking about things like dexamethasone and so on. We have vaccines, and Sri Lanka has ordered booster doses for every single adult in Sri Lanka. So it is important at this moment to get your booster dose and to be protected as much as possible from Omicron. You don't want to test Omicron and find out whether you're going to get severe disease or not. It is much better to take that booster dose and be prepared. So I would like to thank our funding agencies who funded all our studies, our collaborators from the CMC and from Oxford, Professor Graham Morgan and Professor Alan Townsend. And this is our group who have been working, doing all the genomic sequencing, vaccine studies, and other things that I just showed you. Thank you. And it's been such a pleasure to be speaking to you. And thank you for the invitation to speak to all of you about the Omicron situation in Sri Lanka. Thank you.
Thank you so much, Nilika. That was very, very informative and insightful. So we learned so much about Omicron variant, how transmissible it could be. Nilika compared this to measles, which is generally the most infectious viral agent known to mankind, with an R0 of 1 to 16. So one person can give it to 16 in a enclosed space. We have to remember, viral agents like measles, smallpox, chickenpox, and then of course those are all respiratory viruses, and then there are other types of viruses also. Those are highly infectious, highly contagious. The real question is it going to be deadly? Is the virulence all the way up there compared to, say, for instance, the bird flu, right? So that question has not been answered at this point. So because of that, I have to tell you that right now, what is raging across the world is more than Omicron, is the Delta variant, mainly in the cold climates, because most people are indoors, and that be due to multi-generational living and indoor activities, all the Christmas time parties and stuff. There's a lot of transmission. So the best thing to do at this point to get vaccinated and boosted. To get vaccinated and boosted. So the boosters have regular boosters. I'm not talking about Omicron specific boosters, but regular boosters of Pfizer and Moderna have proven very high antibody levels. So that's the best preparation for Omicron or otherwise variant causing another huge outbreak or surge. Now, so there have been multiple questions already asked from us. So if you get if you're vaccinated and booster, you still get Omicron or any type of variant. What are you going to do? Most important thing is to follow CDC guidelines, of course, IDSA guidelines for us. If you don't have any risk factor, you just quarantine. That's it. That's all. 10 days of home isolation and preferably a separate room and a separate bathroom. If you cannot provide a separate room and a separate bathroom, everybody else sharing that space should be wearing N95 masks and air circulation, right? Open the windows. Now in the winter climates, it's very hard to do, but we have to do that in order to control this pandemic. Monoclonal antibodies is a great tool, and those patients who have gotten the infection in spite of the vaccine and the boosters, if you have a high risk, even one risk factor, they should get the monoclonal antibody cocktail. I'm talking about the Delta variant now, Delta and other variants, right? So they should get the monoclonal antibody cocktail. There are two types of monoclonal antibody cocktails available in this country, in the US, Regeneron, and of course, Eli Lilly. So the Regeneron one is given in my infusion center, and we have had 80 to 90% success rate, and which we're going to publish within the next few months. That's a great thing. We firsthand know that these patients have obesity, asthma, or poorly controlled diabetes, or some kind of a ordinary risk factor. They are somewhat immunocompromised, so they require to get that monoclonal antibody cocktail. So treatment-wise, I have a formula that I always talk about, which is called DRAPE formula, D-R-A-P-E. So if you're hospitalized with COVID-19, that means your oxygen is compromised, oxygenation is compromised. You have to have at least 92% oxygen saturation all the time with COVID-19 during your quarantine period. If your oxygen saturation drops below 92%, then you need to get some steroid treatment. And the best way to do it would be to get hospitalized, where we start supplemental oxygen. So the DRAPE formula is dexamethasone, remdesivir, anti-inflammatory agents or inflammatory agents such as tocilizumab if you're in cytokine storm. Anticoagulants, blood clots are very common, so this is for thromboprophylaxis. And then certain antibiotics are prescribed to prevent secondary infections. And then P is for pulmonary protocols. Very, very important. Pulmonary means lung protocol, incentive spirometer, self-proning technique, sleeping on the tummy, very, very important. And the last E is for extras, vitamin C, vitamin D3, and zinc sulfate, and thiamine, and so on. So moving on to the next speaker, Prof. Suranjit Senaviratne is going to talk about this common question, to be or not to be boosted or not to be boosted. Over to you, Suranjit.
Thank you, Deepti. I'll just share my slides. Let me thank the organizing committee and Deepti and Keshini and Chamod for the invitation. Wait, let me open you can see my slides. Let me put it to excellent. So, okay. Yeah. So what I'll do now is give you a sort of a quick update on COVID vaccine effectiveness against Omicron. First two speakers, and Deepti, Dushanta, and Nilika have outlined the position of Omicron, the issue it is causing around the world. And I will bring in the COVID vaccine effectiveness and put the current perspective of that at the present moment. So when we look at effectiveness, we are looking at immune effectiveness and then preventing disease and infection. If you look at the immune system, you have the immune system getting activated when you are exposed to an infection, antibody, the innate immune system, antibodies and white cells as the adaptive. And these have to be working properly, but it takes time to develop. So therefore, because of that, vaccination comes into place because those will be primed early and in place when you are exposed to the infection, to the virus, any variant, etc. And then you have the different antibodies, IgG, IgA, and IgM, which come at different time points. And then you find the CD4 and CD8 cells, which are again very important because that's a cellular component of the immune system in addition to the antibody component. But most of the studies at the moment are concentrated on the antibody component, but we must remember that there's a cellular component, and that I will talk to you when I speak a bit later. So the summary of the talk would be, again, just quickly running through, just to put it back into focus, the Omicron variant, where does it fit in, and some basic aspects, vaccines, booster doses, Omicron and COVID vaccines, study findings, etc., and about vaccine inequity, access inequity as the last point. So if you look at the Omicron basic aspects, this is the virus we're dealing with the spike protein on the surface, binding to the ACE receptor, dividing and multiplying within the cell, spreading from cell to cell and person to person. And we are concentrating on spike protein at the moment because of the fact that most of the vaccines are directed against spike protein. So any changes on spike protein can have an effect, potential effect on vaccine sort of escape. Different variants of concern. These are the variants of concern initially classified by the WHO, and now Omicron has come in, Alpha, Beta, Gamma, Delta, and then you have the variants of interest. And how do we classify them as a variant of concern? There were 5 factors that were considered: the spread, the severe, if it caused more severe disease, diagnostic tests being affected, therapeutic agents being affected, and vaccine responses being affected. So these are the 5 factors. If it was affecting or potentially affecting or having some effect, then it was classified as a variant of concern. And the important thing was Omicron was classified as a variant of concern very, very early by the WHO. So many articles have been written about Delta, Delta Plus, Mu, Delta, Lambda, etc. And then we come on to Omicron, which has been, again, something that has been really focused recently. And we know that it has been spreading around the world and the number of cases have been increasing rapidly. So originally, you have the term there, it was a B number, and then you have 50 gene mutation with 32 in the spike protein and 15 were within the receptor binding domain. That is the part of the spike that really binds the receptor and enters this and allows the virus to enter the cell. In comparison, Delta had 2 changes. So that is an important thing. It made people sit up and take notice because 15 changes, what is the effect with regards to clinical severity and clinical transmission and disease severity. Very different virus to which was originally found in Wuhan. And then some of the mutations, we already knew that it can affect vaccine responses and immunity and the escape from immunity and also transmissibility. So therefore, people took note and then sat up and thought, what can this variant do? These are the different type of mutations. There were not only the spike protein, but the spike protein gene, but in other genes also, which were leading to around 50 mutations in total. So you can see the clustering of the mutations. This figure has been shown by Prof. Dushanta, number of mutations, and this was causing an issue when first described, and people took notice. Again, this slide was shown by Nilika, showing that it really rapidly increased. You can see that beta and delta, when compared to beta and delta, Omicron was rising very, very rapidly. And pandemic, the numbers were increasing. The doubling time was less than 2 days in the UK. So number of cases in the UK. So that was a quick run through some basic aspects of Omicron to bring it into the vaccine perspective. We know that different vaccines, 8 vaccines have been approved, 8 have been rejected, a number of vaccines are in development, or sort of variant-specific vaccines are being developed. And then you have the viral vector vaccine, the Pfizer and Moderna, best vaccines around. Then you had the mRNA vaccines, the Pfizer and Moderna. Sorry about that. mRNA vaccines, Pfizer and Moderna. The viral vector vaccines, AstraZeneca, Sputnik and the J&J, and then you had the kill vaccine, Sinopharm and Sinovac. So these have been rolled out across the world. Many countries have used Pfizer and Moderna, but now with the booster, most countries are using Pfizer Moderna as the booster dose to the population. A question that has come up is about mixing vaccines. That is, homologous is if you give, say, AstraZeneca, heterologous is AstraZeneca, Pfizer, or Pfizer, AstraZeneca, that is two different vaccines. And there's been lots of questions about, can you do mixing? Is it effective? Is it better, etc.? And the sort of take-home message is basically real-world evidence supporting the safety and immunogenicity of heterologous. That is, AstraZeneca, if you've got AstraZeneca, get in a Pfizer, or if you've got two AstraZeneca, get in a Pfizer as a third dose. That is what has been shown. It has been found to be safe. It has been found to be more greater immunogenicity, and mixing vaccines is beneficial in many instances. So then it comes to the third dose vaccine, because in the immune deficient patient, the patients whose immune system is compromised, you go for it with the third dose, which is equivalent to 2 doses in a patient who has a normal immune system. So that is a third dose. And that was approved and recommended very, very early, quite a few months ago in the UK and US, especially in the UK and European countries. So we were giving a third dose in people who were immune deficient. And so coming up that there was a bit of titers of antibodies in the different, especially the Pfizer vaccine, which was found in Israel, etc. There were many studies. The Pfizer study came up first, and then you had the Zoe COVID study, which showed both the Pfizer vaccine and the AstraZeneca vaccine. After about 4 to 5 months, the levels were deteriorating. At about 6 months, the levels had gone below the range that we were satisfied or we were happy. So at that time, then the idea of boosters came in, and Israel was leading on this area. They started boosting quite early. So boosting is it's the third injection for a person with normal immune system, but it will be the fourth injection in a person with an impaired immune system, because they would have already got 3 doses initially. So with the booster, you found the number of cases in Israel started reducing, and it reduced hospitalization, severity, and deaths. Well, it was clearly shown in this publication that came up. So boosters, COVID-19 boosters, are effective, are safe, and this has been rolled out across the world. In many countries, but there's been the equity of rollout is not great, because that is something to be taken into consideration when considered about boosters. So next we come on to Omicron and COVID-19 vaccine. So I've told you that mixing is allowed, mixing is safe, mixing is more immunogenic in many instances. Booster doses are safe and effective. And then we come on to the Omicron and COVID vaccine, because that is the important area that people are looking. In the last 3 weeks, many studies have come. I've just illustrated the first 5 studies that came up to give you a flavor of what are the findings at the present moment. So for the first study was the Durban study, which was the ability to neutralize Omicron. They took some samples, serum samples of 12 individuals. Some were infected before, some were not infected with SARS-CoV-2, and that sent some shock waves initially when it was released. 41-fold reduction in the neutralization, and that was a very important first signal. But the booster doses were not tested here. So that was the first study that came up very early from Durban, and you can see here the neutralization was reduced. Initially, it was the ancestral strain on the left-hand side, and then you have the Omicron, you can see, but the neutralization was not lost completely, especially in the first people who had been infected previous. So 41% reduction in neutralization. Then you came to the next study, the Pfizer study. Again, they looked at 2 doses and 3 doses. They looked at the booster doses, and they found that with the 2 doses, there were 25-fold reduction in neutralization. But when they went and boosted, you found that was correct. That was an important thing to remember, that there was a 25-fold reduction in neutralization, but the data at the bottom is showing that with the booster, that was correct. And that was the importance of booster being given there. They still couldn't look at the severe disease because the important thing is the numbers are small. And the important thing to remember is that for severe disease and so more sort of hospitalization, CD8 cells, it's important because the CD8 cell epitopes, that's the parts recognized on the spike protein by the CD8 cells, that's the epitope, were not really affected as much as the antibody epitope. So that was an important consideration to be had in this. So both the Durban study and the Pfizer study showed that there was a problem with neutralization. The Pfizer study said that it was improved when you gave a booster dose. This was again confirmed in the UK Health Security Agency study, which again showed that after a booster dose, you found that the effectiveness was improved. And it was improved while before, with 2 doses alone, the effectiveness was not. There was a reduction in neutralization as shown in the figure. And if you look at the right-hand aspect of both diagrams, you can see with the booster, the effectiveness has increased as opposed to the level with 2 doses. So that is why people in the UK, they rushed quickly to push out the booster, and they reduced the time period from 6 months to 3 months. They extended to everyone over the age of 18 to give the boosters. And these were the studies that were showing the, giving the lead to that. So there were 3 studies which were looking at neutralization. Then you have the Discovery Health study, which was again an important study that came up looking at the real world data. This was from 15th November to 7th December in South Africa. The number of COVID tests and the number of attributed to Omicron, 2 doses of Pfizer produced a 70% protection against hospitalization. That is important, while Delta had 93%. So it was given 70%, but there was a drop in protection. And this was across age groups and chronic diseases. And with regards to infection was 33% effective. Against Delta, it was 80%. So there was a reduction in the effectiveness to both infection, but we were more concerned about the protection against hospitalization. And that was 70%, at least it was 70%. And against Delta, it was 93%. And that was the Discovery Health data. Oxford study again looked at neutralization and found that there was substantial fall in neutralization titer. They didn't look at the cellular responses. So the priority at this stage is to increase vaccine uptake among the unvaccinated. If the person is not vaccinated, you can't think of boosters because the first thing is to get the first 2 doses. Or if you're immune deficient, to get 3 doses as a first primary response, and then look at encourage the booster doses, because that is the one that is increasing the neutralization titers and is having a positive effect in the group of patients. Now, the important thing is that there was a small study from Germany saying that even with the booster, there was a small group of patients who had some Omicron infection. Therefore, that has been watched carefully because we may need Omicron-specific vaccines. At the moment, the standard vaccines against the older variants are working. But if by chance there is increased amount of escape, then we would be thinking of Omicron-specific vaccines. The companies are working on that. Pfizer and Moderna are working on that. They have said that by about 3 months, by March, they should be able to get a sort of a vaccine to the regulatory authorities to be approved. But still, at the current moment, it is the standard vaccine that we're using now with a booster that has been found to increase the neutralization capacity at the present moment. So this is a timeline with regards to Omicron-specific vaccine. It takes some time. We have to just tweak the vaccines. It's easier to do with mRNA vaccine. That is what is being done now by Pfizer and Moderna, and these will be available. But the important, would we need it, is the matter to be followed very carefully, because at the moment the current boosters are doing having the effect that we want. So then we come on to vaccine access inequity, because that's an important area. We are talking about boosting, etc., in one part of the world or 2 parts or 2 regions of the world, etc. But there is inequity of vaccine access, and this leads to continued uncontrolled transmission. and this leads in turn to increased chance of new variants. So if we have Nigeria getting only 1.8% of the population getting 2 doses, when other places have 60%, this is not going to control the pandemic overall. So much debate has been there about the use of booster vaccine doses. The important thing is to stop the continued spread of SARS-CoV-2 virus, good access to COVID vaccines in lower income countries. People staying in high income countries cannot only look at their population and say we should vaccinate, give boosters to 80, 90, or whoever takes the booster doses, because you have to think of the world. Otherwise, a variant will arise and cause more issues and vaccine escape, etc., as we are seeing, and then that whole process can be affected. So we have to consider vaccine access in it, and WHO has really drummed that down importantly. This just gives you an illustration. In Nigeria, 1.9% have had 2 doses of those who are eligible, 1.9%. UK, it's 69.7, Sri Lanka, 62.9, India, 38.4, a massive country. It's less than 50%. Booster vaccine doses as of 12 December, world, it's 4.7, UK, 36.7, US 17, Israel 44. So we could be in one country and say, oh, excellent, we are having a lot of people getting boosted. Sri Lanka at 7.5, Nigeria and India, none. They have not started because their 2-dose rate is low. So we have to remember that process, because we cannot just forget about and only think of one part of the world, because that will cause problems across the world. So in summary, what I've done so far in this talk is giving you an overview of where does Omicron fit in with the different variants, the important variant of concern, spoken about the mixing of vaccine, the booster dose, and that is safe and effective, spoken to about the 5 studies, that are other studies, the Imperial study, the Hong Kong study, which has also come up, which I didn't talk about, Omicron-specific vaccine, would we need it? And vaccine access inequity is a very, very important point to be discussed. And some of the points have been discussed in this sort of article that has been written, that boosters are increased protection against Omicron, the variant. Thank you.
Excellent, outstanding. Thank you so much, Saranjit. That's very valuable information about vaccines. So as Hamlet goes, to be or not to be, it's definitely to be. To be boosted is the best way to protect yourself. So among the questions that I received, some people have asked, if you still get the vaccine, how do these variants occur? Of course, when you let the virus replicate, this kind of respiratory viruses diversify. They diversify into different variants because of mutations. So the best way to control this will be to provide equitable access to all the countries at the same time, so that we can create herd immunity to a level about 70 to 80% at the same time. It's not happening right now. What is happening right now is the world is so globalized now that people who are vaccinated have started traveling, sometimes regionally within the country and internationally too. So this is going to create a lot of problems. So please be careful, but you cannot not travel also, because we have to get on with our lives as well. But the best way to do this would be to protect ourselves, would be to be vaccinated, boosted, and use the mask and use the monoclonal antibodies wisely. So now there was another question. So if vaccinated people also get the infection, what's the point in getting vaccine? Well, the problem there is we have to understand that we are not living in a bio bubble, individually speaking, right? If we are vaccinated and boosted, the chance of that's personally, right, us going into a hospital or hospitalizations or ICU admissions and death is minimum, no question about it. But we can still get we don't have the IgA protection to the nose. We can still get an asymptomatic infection and give it to some immunocompromised person living with us. Elderly patients with biologic agents nowadays, steroid treatment with asthma and COPD, patients with chemotherapy, patients who are undergone transplants, solid organ transplants. So all those are considerations that we need to come up with in our own mind before we think about getting vaccinated and boosted, as to why we are doing that. Last but not least, let me introduce Dr. Sanjay Sinanayake from Canberra, Australia, to talk to us about Australian approach to Omicron variant. Over to you, Sanjay.
Thank you so much, Deepti. I'd like to thank you, Keshini, and the Sri Lanka Foundation for having me speak today. And I've really enjoyed the talks, and I've been making furious notes while my predecessors have been making a number of good points today. So I'm going to talk about, well, Australia's response to Omicron. We're sort of very early days in our Omicron talk, and I hope you can see the presentation now. So I thought, because I'm in Australia, I'm in the distant part of the world, and many of you are in the Sri Lanka, the Northern Hemisphere, I might also just talk about our approach to COVID in general, and then talk about what our recent experience with Omicron in the last couple of weeks. In terms of my talking points, and again, please put a buzzer in about a minute before I'm meant to finish. I'm covering quite a few slides, but I'll try and do so in an efficient manner. So I just want to talk about Australia's political, geographical structure, health system, and overview our COVID situation, what helped us, what hindered us. Hotel quarantine, there was a high court case of interest, and I guess moving towards Omicron, looking at our vaccine program. So this is Australia, 25.4 million people. I like to think of it, population of Sri Lanka, and Sri Lanka is the size of Tasmania. So that's what I tend to think of it that way. The most populous cities are Sydney, Melbourne, and Brisbane. And we've got universal healthcare. So this is something I put together when I was just scribbling one day, just trying to think how we communicate with each other in Australia. This was at the start of the outbreak. And actually, although there are a lot of boxes and it looks a bit confusing, it does show that there's a lot of communication. And I just want to see, is there a way I can use a little arrow? I'm trying to use an arrow, but I don't know if it's coming on screen at the moment.
Not really.
Okay, that's fine. I'll just talk. But you can see from here that we have, each state has a chief health officer. The Commonwealth, the federal government, has a chief medical officer. And in the center, we've got a committee, the Australian Health Protection Principal Committee, where they all speak together. Then above them, they all report to their state or federal health ministers. And again, those health ministers have their own advisory council. And the health ministers report to the cabinet. And now we have something called a national cabinet. So we've got multiple levels of reporting, and people know each other. They communicate with each other regularly. And below all that, we have centers of excellence, laboratories, epidemiological centers, etc. So we've got all this information feeding back and forth in a fairly collegiate climate. At least that's how it started, and it seemed to serve us well. Now, at the moment, in terms of COVID cases per day per million people, Australia is still doing well, but we are seeing a surge due to Omicron. But certainly compared to a lot of other parts of the world, we're doing well, and we've done well throughout this outbreak. So if you look at the summary statistics, we've had about 240,000 total cases of COVID, about 2,100 deaths. If that's equivalent to about 25,000 deaths for the US. And the US, I think, has had, around 800,000 deaths. So Australia's done quite well. And it's sort of really in recent times and in the middle of last year where we accounted for most of our cases. Now, there are a few reasons that Australia's done relatively well to this point. Population density, early border closures, being an island, united leadership at the start, testing, and a job keeper program. So, as many of you know, Australia's at the other end of the world. So while COVID was wreaking havoc in the Northern Hemisphere, it was much harder for it to get to Australia. Even though we know now 1 billion people traverse international borders every year, it was just that much harder for COVID to travel to the Southern Hemisphere. In terms of population density, compared to lots of other parts of the world, Australia is very low. Now, the arrows have got skewed, unfortunately, but Australia has population density of only around 3 people per square kilometer because of the large desert areas. Now, that, of course, in Sydney and Melbourne is much higher, but even then, it's about 1,000 on the list. So population density for a respiratory virus that predominantly spreads by droplets is an important factor. On March 20th, Australia shut its borders. So it did so very quickly. And some parts of it, such as Western Australia, one of our big states, has not opened up at all. And that's one reason why we saw so few cases compared to other parts of the world. I mentioned National Cabinet. We used to have something called the Council of Australian Governments, COAG. And there you see the gentleman in the white shirt is our current Prime Minister, Scott Morrison. And on the screens behind him are the various state and territory premiers and chief ministers. And they would meet regularly, twice a week. They would come in front of the camera as a group, and it would be very reassuring to a nation who was very scared about this new virus. And I think in a lot of parts of the world, we didn't see that sense of collegiality between federal and state governments. So for us, it was very reassuring. Now, unfortunately, with time, that has been eroded somewhat. They still meet, but they're not always so united. The other thing which we really tried to encourage in Australia was for people to socially distance and not mix with others if they thought they might have COVID. And if you are dependent on a salary to pay your mortgage, to feed your family, to take care of all those important expenses in your life, then people will circumvent those restrictions. So the Australian government put in JobKeeper, which cost over 100, probably closer to $200 billion at the end, over 6 months. And it basically paid people to be at home. And that really did help with compliance. Now, as we had more and more lockdowns, in fact, Melbourne is the most locked down city in terms of number of days it has been in lockdown. It's the most locked down city in the world. As we had more and more lockdowns, compliance dropped enormously. But certainly at the start in 2020, JobKeeper definitely made a big impact. And we're lucky, we're a rich country, we were able to do that. Testing in Australia has been really good. The public have generally responded really well to testing. Now, COVID testing in Australia is completely free of charge, whether you do it in a government hospital laboratory or if you do it in a private laboratory, the government foots the bill. So that's been very helpful. In terms, as you all know, if we think we're capturing most of the COVID cases in our population, the percentage of positive tests should be less than 5%. So that suggests that you're capturing most of your cases. Right now in the United Kingdom, where they're seeing this explosion of cases, and as Omicron seeks to dominate Delta, we're seeing about 10% of cases of tests being positive, suggesting there are lots of cases out there that are still being missed. This is from the CDC, and it shows that in the US, the 7-day positivity average is 7.2%, so still above that 5%. So there are cases out there which are being missed. In Australia, we're having a big surge. So the third column, or third row in blue, New South Wales, NSW, is still under 1%. So we've managed to really not get not get too far above 1%, even at the worst part of our outbreak. So that's been very helpful in making public health confident they're capturing most cases. Things that haven't been so good, we had an app called the COVID Safe app, spent a lot of money on it, and it wasn't a great success. And that's in contrast to places like South Korea, which really use technology well to control outbreaks. But that's another story. Now, something which wasn't so good, there was a cruise ship which called the Ruby Princess. The passengers disembarked in New South Wales, and this unfortunately led to over 900 cases being released into the community and about 28 deaths. Last year, so before we were using the Greek alphabet for variants, we had our biggest outbreak in Melbourne. And we learned a number of lessons from that. So the first one was with contact tracing, it's better to have a decentralized system rather than a centralized system. So in New South Wales, we do have a Department of Health sitting in the center of Sydney, but within different suburbs and regions within Sydney, you have localized public health units, sort of different satellites with lots of people in them who know the area, know their local community, and we found that that was a more efficient way of getting data. Whereas Victoria, where Melbourne is, it was very centralized. In Melbourne, they were still using faxes and paper, and problems were occurring with that, and now they've moved away to a more electronic system, and their contact tracing has become more efficient. Lockdowns, though they were terrible, we learned that they work. They did make a difference. And we've seen that time and time and again around the world. And they achieved elimination, but I'm going to talk about that in just a sec. The other thing I quickly mention is hotel quarantine, because in different parts of the world, hotel quarantine manifested or incarnated in different forms. So I think the UK, from memory at the start, didn't have any form of hotel quarantine for returning overseas travellers, but I believe that's changed. But I'm happy to be corrected about that. Now, we did have a hotel quarantine scandal in Melbourne. And on the right, you can see that Four Corners, which is an investigative current affairs show, found the security guards sleeping, fast asleep when they're meant to be guarding all these hotels and preventing travelers from moving inappropriately. And that's bad enough when they're asleep. But when they got awake, if you look on the left side, they started having sex with the travelers who were meant to be in quarantine. Now, you don't need a degree in infectious diseases or epidemiology to work out that that's not a good way to prevent COVID spreading. So anyway, that was an embarrassment for the state and the country, because a lot of people picked that story up, and we learned how to better recruit and train security guards for this most important position. It led to a hotel review of the hotel quarantine, and hotel quarantine overall in Australia, it's been a variable success. About under 1% of people who entered hotel quarantine ended up having COVID. So the percentage wasn't great, but the problem was we had about 26 or 27, somewhere in that ballpark, breaches of hotel quarantine in one form or another, where COVID went from hotel quarantine into the community. So even if you've only got 1% of people with COVID, 26 or 27 opportunities for it to escape into the community is a terrible thing. So we really have been recommending to the government to get better facilities rather than hotels for quarantining return travelers if we're going down that pathway, although things have changed now. The other thing that's happened here, as I mentioned, everything was very united at the start in terms of the state and territory governments. But what happened in Australia later on is that some states and territories got more COVID than others. And when that happened, certain states closed off. So below Scott Morrison, the Prime Minister is Mark McGowan, the Premier of Western Australia. The lady on the bottom left-hand corner of the screen is Premier Palaszczuk of Queensland. And they had very restricted movement in terms of their borders. As Australians, we used to think the Commonwealth controlled the borders, but what has become apparent is throughout COVID is that the states have enormous amounts of power. The man with the thumbs up is not a politician. Well, he was actually for a short period, but he's a businessman, a billionaire mining magnate, Clive Palmer. And he did not like being in Queensland and having all these restrictions in coming to his mines in Western Australia. So he and the federal government launched court cases against Queensland and Western Australia to try and say that it was not legal or legitimate for the states to have their borders closed. Unfortunately, they lost, and it just reinforced the power of the states to control their own borders. And that's, it was all based on, the whole argument was around Section 92 of our Constitution. So then, in epidemiology, when we're talking about infections, we talk about elimination versus suppression. So eradication is having no infection in the world. We've only done that with smallpox. With elimination, that we have no infection in a certain region, but the problem is that it can reoccur because it's in other parts of the world. And control or suppression is accepting a certain level of circulating infection, like we do with the common cold or we do with influenza, etc. So with Australia at the start, it was all about being COVID zero, having no COVID, elimination. We are going to move towards elimination of COVID. It might be in other parts of the world, but we won't tolerate it in Australia. And there were pros and cons because most parts of Australia had achieved elimination, but the most populous states, Victoria and New South Wales, had not. And the wonderful thing about achieving elimination, we wouldn't have to worry about border controls and restrictions because there wouldn't be any COVID in Australia, and we could go where we like to, from Sydney to Melbourne to Perth, unimpeded. However, we also had to deal with the fact that overseas travelers would be coming to Australia and they could have COVID. So this was a vexed issue for some time. And Victoria got to elimination stages in 2020. However, as I said, elimination is a temporary state, a temporary phase. It's always going to be surpassed by infected people entering that region and leading to another outbreak. So back in January 2021, my feeling was periods of elimination in Australia are achievable, but it's a temporary state while overseas travelers come here. But then that big spike on the right-hand side of the screen was when Delta reared its ugly head. And we came to the conclusion very rapidly in the states that were experiencing Delta, so New South Wales and Victoria, and then the ACT, where I am in Canberra, that elimination was not feasible. We had to live with COVID. So COVID zero got thrown out of the window. Western Australia clung on to it for a bit longer, and they will open their borders on February 5th, but even they are accepting that you cannot live in this world without COVID at the moment. Life has to move on. And in fact, really, I think apart from China, who are trying to achieve COVID zero, I don't know if there's anyone else who's really trying hard to achieve that. It just seems too hard with Delta and now Omicron, which is 2.5 times more infectious than Delta, as we heard, potentially achieving measles-type reproduction numbers. So we had our vaccine rollout in February 2021. We waited a couple of months to see what would happen in the Northern Hemisphere and make sure there weren't any unexpected side effects and see if there were any major problems with the rollout. We had the Pfizer vaccine, the Oxford AstraZeneca, Novavax. We bought a number of tens of millions of those. We were part of the COVAX program to distribute vaccines to less fortunate countries. and we had a University of Queensland vaccine, which is a protein subunit vaccine. So that technology, we see that technology a lot with tetanus, hepatitis B, etc. But they had something called a molecular clamp, which was unique to their vaccine, which they felt made it more likely to stimulate prolonged good immunity. And where is Australia at the moment? Well, we were coming 17th. Now, again, I haven't got a pointer here, but on the right-hand side, Australia's got 77% of the population fully vaccinated, with about 5% having had boosters. We're coming about 17th equal. And on the left-hand side are the countries below that right-hand side. So the US, which was far ahead of us, has gotten behind. They sort of peaked early and haven't moved too much more since then. And even the United Kingdom is behind Australia at the moment. And Sri Lanka is sort of in between at about 63%. In terms of our national vaccination progress, in terms of people over 12, 89% of the population is fully vaccinated. In terms of different states, they're relatively even. The states like Queensland, South Australia, Tasmania, who haven't had much COVID, are a bit lower in their vaccination uptake, but pretty close to us. Where I am in the ACT, 99% of people over the age of 12 are fully vaccinated. We think we're the most vaccinated city in the world, but can't prove it. But we had a very slow rollout to start with. And we had supply issues because before local production began. There was a lot of vaccine nationalism. We were relying on vaccines to come from Europe, but because Europe was seeing so much COVID, they wanted to keep vaccines for themselves rather than distribute them. Then we eventually had CSL, our big local vaccine manufacturer, start manufacturing the AstraZeneca vaccine in very large amounts. However, the problem with that, there were a couple of problems. One problem was the University of Queensland vaccine, which looked so promising in terms of giving a good immune response, had to be scrapped. The reason is that part of the vaccine used part of the HIV molecule, virus molecule. So, or part of the HIV virus. So what it meant was that if you got the University of Queensland vaccine, you didn't get HIV, but you might get a positive HIV test. And for that reason, the vaccine was scrapped. Then with AstraZeneca, which was being produced in bulk in our CSL factory in Melbourne, we had problems with the thrombosis with thrombocytopenia syndrome. And the reason I'm specifically mentioning this is many of you are in the United States, where just now the Johnson & Johnson vaccine, which is a very similar vaccine to AstraZeneca, it uses an adenovirus vector technology. They're having similar issues coming to terms with rare clotting events. And I think you've had 9 deaths, which means the death rate's about 1 in 2 million. With AstraZeneca, we were seeing 1 in 1 million in Australia. But so you're having similar problems, but you've had your FDA say that Pfizer and Moderna are preferred over the Johnson & Johnson vaccine. And I think that mixed messaging will be the death knell to Johnson & Johnson in the United States. We've seen a similar thing in Australia with where the messaging for AstraZeneca, trying to convey how good the vaccine was and how rare this fatal side effect was not done particularly well. To show it really, your risk of dying from a blood clot after a dose of AstraZeneca vaccine, it's probably even lower with the Johnson & Johnson vaccine. Well, comparatively, you're just as likely to be struck dead by lightning in Australia, and you're more likely to be drowned, killed, or be in a car accident, or perhaps be murdered by drowning. I'm not sure. But the risk is really low, but it was never conveyed like that. And AstraZeneca suffered in terms of our vaccine rollout. But the factor that gave impetus to our vaccine rollout was that big peak at the right-hand side. That is when we started seeing a lot of cases. We started seeing people go to hospital. And I remember being asked by foreign journalists when our vaccine rollout was slow. Why is it so slow? You're a rich country, you've got a good record of vaccination. Why is it so much faster in the US and UK? And I said, look, that's because you've got COVID. People understand what it means to have a lot of COVID, the risks, the dangers to themselves and to loved ones. And that has been borne out by what happened in Australia. As soon as we started getting big outbreaks of COVID, that was the impetus for everyone to get vaccinated. And we haven't looked back since. New South Wales is having the bulk of the Omicron infections, but it's being found in other parts as well. But you heard previous speakers talk about how rapidly it's growing, doubling every couple of days. Now, Delta is still, we think, the main dominant virus, but it will soon be overtaken by Omicron. So we're expecting to see lots and lots of cases, but thankfully we are a heavily vaccinated population. So hopefully that will protect us, and at worst, we'll be able to provide the world with a lot of data, good data about Omicron in a developed world vaccinated population. The other things which didn't help the rise in cases, it wasn't just the emergence of the variant of Omicron. This is from New South Wales. This is a press release about New South Wales from the Guardian newspaper. From the 15th of December, masks will only be required in certain situations. QR code check-ins, if you're going into a venue, will generally be dropped, and density limits were to be dropped for all settings. What I keep trying to tell people is this: we have not got the vaccines that will give us herd immunity to SARS-CoV-2 or to COVID-19. We just don't. We've got some great vaccines. They've been rolled out so quickly, but they're not good enough by themselves to stop COVID circulating in our community. Our strategy against COVID is part of a bundle of strategies where vaccination is the most important, but other things, wearing masks when you can't safely physically distance indoors, trying to avoid being indoors if you can be outdoors when you're having gatherings, which is easier in our Southern Hemisphere summer than your Northern Hemisphere winter. If you're indoors, making sure you maximize or optimize the ventilation. Use QR codes when you go into venues, so if there is a big outbreak, public health can easily track you and prevent further cases from occurring. And if you think you have COVID, go and get tested. As I said, in Australia, it's really easy and accessible. In response to Omicron, a few states have decided to bring mask mandates back in certain situations, which I'm very grateful for. The government was advising for people to have a booster 6 months after their second dose. We've now followed Israel's initial recommendation of 5 months after a second dose, just because of Omicron. But if Omicron becomes a big problem, that might shorten even further. Up till the 1st of November, rapid antigen tests weren't being used widely in Australia, and they weren't allowed to be used outside the laboratory or the hospital setting. But from the 1st of November, a whole host, 13 different types of rapid antigen tests, some nasal, some salivary, are available for the public to buy. In fact, I bought one about a week ago. My daughter went away with a group of friends down the coast after she got back, because they'd been mixing with people from New South Wales. I had her and her friend tested, worked perfectly well, very simple, and it was reliable in that setting. If you come into an Australian hospital or to a health system in Australia and you're notified to have COVID-19, in the community, certainly where I am and in other parts of Australia, you'll be offered inhaled budesonide and a monoclonal antibody called sotrovimab. And sotrovimab has been tested against Omicron, and it looks like it still works, which is great to see because some of the other monoclonal antibodies don't. So Regeneron, which President Trump got, doesn't seem to be as effective against Omicron, and they're having to adapt the formula for that and adjust it. If they prevent you coming into hospital, that's great. And that's usually within 5 days of your infection, and typically in people who've got risk factors for severe COVID, so obesity, bad lungs, bad heart, diabetes, etc. But if you do end up in hospital, you tend to be offered dexamethasone, remdesivir, and tocilizumab or baricitinib. Dexamethasone being a very common immunosuppressant like prednisone from that sort of same family of steroids, which has been shown to reduce mortality in really sick hospitalized patients with COVID. Remdesivir, which is a dedicated antiviral, initially developed for Ebola. And tocilizumab and baricitinib, they're immune modulators, so they further dampen down the immune system. So that's me dressed up for working. I think that was first day of working on the COVID ward. And I must admit, the COVID ward in Canberra Hospital is the safest place in Canberra. Everyone knows what to wear. They're very careful with their personal protective equipment. We've got medi hoods, we've got negative pressure rooms, we've got portable air filters everywhere. So I feel very safe there compared to going to a shopping mall or a supermarket. So thank you very much for the opportunity to speak today.
Great. Thank you so much, Sanjay. That's incredibly important to hear your side of the story from all the way from Australia. Quick questions, to answer a few quick questions. Is it safe to take booster vaccines in any trimester of pregnancy? Suranjit?
If possible, to go on the second and third trimester and miss out on the first trimester, but with Omicron coming, that may change, and people have been advised to take the booster at any trimester, but generally if you can, get it onto the second and third trimester.
Great. And then what's the best time to take the booster dose? There's an argument saying that the best time to take it is 6 months after the second dose, but in Sri Lanka, it's given 3 months. Appreciate if you could provide an answer. Suranjit, once again.
Yeah, so I think it's a moving target. I think we have to remember that when it comes to COVID, you give an answer in June 2021, and then in November 2021, we are revising it. So initially it was 6 months, then Singapore and Israel came to 5 months. After Sri Lanka came to 3 months, and at times people did not know why that 3 months were decided, and there was a bit of confusion. But then when Omicron came in, the UK government reduced it from the JCVI, reduced the time to 3 months. So now it's 3 months to everyone over the age of 18. And they're trying to give the booster by 31st December. So that is it has been a moving target, Deepti. That you can't say one answer is correct and one answer is wrong. Actually.
Yes. Yeah, and also I had to mention that several of my patients actually got boosters in between the times that they required, because they were immunocompromised. They were very proactive. They got their antibodies tested and they were down to 0. So obviously some of them got their vaccines or the boosters even before the CDC recommended that. There's another question about low platelet counts.
Can I make a comment on that?
Yes, Dushyant.
Yeah,
sorry.
I think that the classic time, as Suranjit said, was 6 months. So there was a question about why Moderna and Pfizer gave their second shot at 3 to 4 weeks. In fact, when this was questioned at one of the conferences, the argument was that we had to do something to get a boost up, but the ideal time would have been 6 months. And I looked at the data from Janssen. In fact, Janssen, when they give the booster at 6 months, they can get a much higher bump than giving it, say, 2 months, because Janssen has started doing second or third shots also.
Right, exactly. So I'm sorry about the Johnson & Johnson vaccine, Dushyant. So CDC, as Sanjay pointed out, preferentially selected mRNA vaccines in this country because of the side effects. Okay, so is the antibody buildup after 2 doses of Sinopharm similar to or as good as the mRNA vaccines? That's a question for Suranjit again.
Yeah, no, absolutely. Sinopharm is the weakest vaccine, Sinopharm and Sinovac, because it's expected that kill vaccines, you don't expect wonderful, you don't expect the best responses from a kill vaccine, but they were important at the time they were given, because you had to roll it out There was no other vaccine, had to roll it out around the world. Sinovac is the most widely used vaccine in the world. 2 billion doses have been given. So we have to remember, we are not dealing with one country alone. In the UK, we don't have the Sinopharm and Sinovac. In Sri Lanka, they had to use the Sinopharm and Sinopharm vaccine, and like what UAE and Bahrain did. But after that, come in with a boost of a Pfizer vaccine or Moderna.
Exactly. So you have to remember all the vaccines FDA approved and CDC approved and of course WHO approved have the potential to minimize deaths and hospitalizations as 98 to 100%, pretty much. So Sinopharm being an inactivated vaccine has the same potential. Last but not least, last question. I had lots of questions, but we don't have time. We're running out of time. Why is it required to wait 6 months for the booster shot if somebody already been positive for COVID? Sanjay, you want to take that question?
Yeah, so, well, we're not entirely sure, but we wonder if someone, the concern is if someone has a booster shot after getting COVID. So that's the question, isn't it? If you've had COVID, then getting a booster, it might interfere with the immune response to the booster, because soon after COVID, you'll have an enraged immune system with lots of antibodies and other parts of your immune system very active. So you let that settle down and then you can have your booster. That's why we say 6 months.
Exactly. So for people who are hospitalized with severe COVID-19.
Can I just add in that we just wait only 1 month here in the UK. We don't wait 6 months. So even if you get a COVID, even if that's an important question at the moment in Sri Lanka, a lot of people are asking that. So if you have had 2 vaccines and you're eligible for a booster, that's an important thing. 2 vaccines, 2 doses, and you're eligible for a booster, right? That's the important aspect. Not if you have the 2 vaccines in say November, then you're not eligible for a booster. But if you're eligible for a booster and then you get COVID just before getting the booster, we wait 1 month and give the booster. We don't wait 6 months, because with Omicron we don't wait so long. That's an important thing because Sri Lanka, it's wondering. Yeah,
that's a great point, Surendra. Thank you. And the Omicron variant, is it still detectable with rapid antigen tests? Now, I had to tell you, rapid antigen tests do not depend on S protein. It's mostly nuclear capsid protein. Is that true, Suranjit?
There are a whole range of rapid antigen tests, and I think some of the problems with rapid antigen tests, I mean, they've been good, they're very widely used, etc. But always then with a positive test, you must go ahead and confirm with a PCR test, because that's a gold standard.
Yeah, definitely. But the question is, do rapid antigen tests detect Omicron variant? I had to tell you, Omicron or any other variant is detected with a test called whole genomic sequencing, right? Not with your routine PCR or rapid antigen test. Now, will Omicron or any other variants hinder or cause or create something that we call S-drop or N-drop, meaning not catching go ahead.
S-drop, yeah, exactly, because that's how they've identified, because I mean, even South Africa, etc., sequencing is definitely less than many parts. I mean, they do sequencing compared to Africa, but that S-drop is the important thing which points to the possibility, as opposed to Delta, Omicron was fine having that S-drop, definitely, yeah.
Yeah. What about somebody who has low platelet count? Is it advisable for them to take a Pfizer booster?
Yeah,
I think that's the
absolutely.
group that should have one.
Yeah, absolutely.
Well, the question is it safe to have the Pfizer booster for a person who had 2 vaccines of Sinopharm, as well as having less platelet count? So we need to reiterate the fact that all kinds of patients, all kinds of diseases, including autoimmune diseases, are out there. I mean, I did a study on, of course, Guillain-Barré syndrome, right? There are much more Guillain-Barré syndrome caused by COVID-19, and I had quite a few patients, and also Miller-Fisher syndrome, a variant of Guillain-Barré syndrome. So it's a classic scenarios. So thrombocytopenia may or may not be related to Pfizer vaccine, but definitely with viral vector platform, it's been well documented that syndrome that Sanjay described. So yes, definitely they have to get their vaccine. And there's another question: is this booster vaccine teratogenic? Meaning, teratogenic. Sanjay, you want to take that question?
So there's, we're learning a lot about the booster doses. I mean, it's just the first few months, but remember we're using vaccines that we've been using for the last year, and there's no evidence of teratogenicity with the mRNA vaccines. I mean, here Pfizer is the recommended vaccine for pregnancy, so no,
exactly.
Not an issue.
That's right. Yeah. So I think we're gonna stop at this. We are running out of time. It's 10:20 here. Thank you very much. In closing, I would say Omicron is a real thing, but we don't need to be alarmed unnecessarily. But we have to appreciate the fact that we are facing a Delta surge, and especially in the Western world and in the temperate climate. So please be careful, check your vaccines, be vaccinated and be boosted, and wear your masks, and believe in monoclonal antibodies. Whatever Dushanta said, believe in monoclonal antibody cocktails. And if you have a high risk for severe disease, definitely go get one, because it still may work for you, because we don't know what variant you have. It is the Delta variant or Omicron variant. Only 3% of US cases diagnosed with COVID-19 are so far Omicron, but Delta, basically a great majority of them. So thank you very much, Keshini, Chamod, and the crew who always help me to get this going. And hopefully we'll come up with another presentation, much more favorable one, in a few months' time. Thank you. Over to you, Keshini.
Thank you, Dr. Deepti. But I just saw a question from Chamod. Do you want to answer that?
Yes, which one is that?
He's asking, what can we do to protect ourselves who already have taken boosters
from
Omicron if we go for an indoor gathering at home in the coming weeks?
So in the coming weeks, that's exactly what we said, right? In the coming weeks, it's going to be very cold, especially in Europe and US, Canada, and of course, Australia is the other way around. So indoor gatherings, we need to open up. We need to have the windows, doors open. If you can heaters going on, that's even better, and people need to be wearing masks preferably. But the most important change the CDC did recently was testing protocols changed. So if you have to attend an indoor gathering, and if you're high risk, you would expect everybody to have a rapid antigen test done prior to that. And those rapid antigen tests are available over the counter now, and those are relatively inexpensive, $20-30. But if you don't have the means, then it's covered with insurance. So that's the most critical part of indoor gatherings going forward next 3 to 4 months. Dushanta, anything to add to that?
No. I think that's exactly we would say. You can't stop people from meeting, you know, but we can take precautions. Take
precautions for sure. Yeah. Thank you so much. Yeah. Over to you, Keshini.
Thank you, Dr. Deepti. The rest of the questions, I think there's a few that came in, but I think it's getting late, especially for Dr. Dushant and Dr. Saranjit. It hasn't slept all night. He was at a dance, I know, in London. So I don't want to take too much of their time. But you can email the questions to me, talking to the attendees, so then I can kind of forward the questions over to the doctors. Thank you. I'm going to invite our Chief Operating Officer, Shirani Stanislaus, to convey the vote of thanks. Shirani, over to you.
I guess.
Good evening and good day to everyone present today. The panel of doctors, Chairman of the Board, Dr. Walter Jayasinghe, President Dr. Dishan Jayasinghe, Vice President Mrs. Aisha Jayasinghe, Chief Executive Officer Mr. Rodney PERAHERA, and the staff of Sri Lanka Foundation International USA, and all the participants. It is such an honor for me to get the opportunity to thank you all. On behalf of Sri Lanka Foundation International USA, I extend a warm welcome to everyone. I would like to express my gratitude to the doctors for their presence, taking the time from their busy schedule and their contribution to make this informative webinar a great success. It was really great. A special thanks to Keshini Vijay Gunaratna, our Director of Project Management and Public Relations, and Chamo Damarasinghe, our Media Director, for providing immense support and coordinating everything and organizing this webinar. Also, I want to thank Rodney PERAHERA and Achala Veerasinghe, Director of Cultural Affairs, for their contribution as well. Thank you everyone once again for participating and making it a great success.
Thank you, Shirani. Once again, a special thank you to the panel of doctors. It's such a pleasure, like Shirani said, listening to the presentation. I learned so much. Thank you again to the attendees for being part of our webinar, and happy holidays. And
Happy holidays to you.
next year.
Happy holidays.
Happy holidays.